concerning the situation of maxillary anterior group. So first we start by the mandibular anterior group. I would like to go back a little bit because I forgot to explain really the reason why we have to start by the anterior group, mandibular anterior group. Okay. The reason is the morphology is the simplest morphology of all the teeth. For the four incisors are the same. Little bit large for the lateral incisors, but not a problem. The shape is very simple. The difference between the canine and the incisors are not very strong, just the tip of the cusp. Little bit the lingual face, but this teeth works only by the top of the cusp on the free edge or with the free edge. So it is easy to adjust the occlusion. It is easy to wax it. It is easy to define the form morphology. It is easy to define the position. It is easy to control the occlusion for the 6 teeth. It is the first exercise for the student to make a wax up of the mandibular incisors. And the last argument is it is a way of the nature. Because mandibular incisors are the first permanent teeth which erupt in the mouth. So the reason of the starting point of the occlusal schema is the simplicity. And why I insist on this point is because frequently people think we have to start by the maxillary incisors, which is alpha and omega of occlusion. No, maxillary incisors are alpha and omega of aesthetic, not on the function. No, but we have to discuss the situation of maxillary anterior group. I'm looking if there is questions. Okay. Concerning the anterior determinants of maxillary teeth, there are a lot of informations. Especially in aesthetic dentistry. So I will be short on this topic. The mean height is classical. We need 4 millimeters of overbite. 4 millimeters of overbite. 2 millimeters is insufficient to have an open guiding system. We need 3 or 4 millimeters of overjet. Absence of overjet is anterior interference. But The maxillary anterior group has a dual role. The buccal face is concerned by aesthetic criteria. The lingual face is concerned by functional criteria. And it is two different steps. There are no correlation between the morphology of the buccal face and morphology of the lingual. When you know the morphology of the buccal face, we don't know the morphology of the lingual face. Different objectives. And so two different steps during the construction. At this moment, we are concerned by the criteria for the buccal face. Only this one. Dominated by aesthetic criteria. After we can discuss, after the definition of occlusal plane, we can discuss on the lingual morphology dominated by functional determinant. Concerning the aesthetic rules, it is a very frequent topic for lectures, so I will be very quick. I am not only interested by the position of the free edge of the maxillary incisor, I am interested also by the position of the canine, the relative position of the tip of the canine with the lip. The interesting things are asymmetric case. It is. And it is a very pretty lady. And it is asymmetric. The midline is not in the mid-sagittal plane. But from my point of view, there are too much teeth in the mouth. Okay. How to build anterior teeth? Starting point is the limit of the gingival limit. You can play a little bit with this, with the adaptation of the pink tissues with the gingiva. It is cervical point. After we have the free edge, but the buccal part of the free edge, the buccal free edge point, defined by its relation between the lip in rest and in a smile, on a large smile, and so on. And with this, you can define the limit for the wax up of the anterior part. But no information concerning the lingual phase. For this patient, Philip needs aesthetic restoration. He demands aesthetic restoration. It is a symmetric case. Okay, mounting the cast. And it is aesthetic analysis concerning the smile, the rest, the face, and so on. And so we can have some information concerning aesthetic morphology. And we can wax after the anterior group, the anterior, and after the mandibular anterior group, you can wax the buccal face of the maxillary anterior group. Nothing on the lingual is adjusted there. At this time of the wax-up, we have only the anterior group, only the anterior face of the anterior group, the buccal face, sorry, of the anterior group. Okay, I was short on this octave 5. The main point that I like a lot, it is the distribution of occlusal plane. If you look at this case, I show it at the beginning. It is a caricature of dentistry. No function is possible. We have to think about the inclination of the occlusal plane. We have to speak about the morphology of the curve of SPI. First of all, there are no correlation between occlusal plane and compare plane. So compare plane cannot be used like a reference to determine for determination of the occlusal plane. The typology of the patient is a really determinant of the direction of the occlusal plane. In an open bite case, the occlusal plane is inclined. Sorry. For deep bite case, the occlusal plane is more horizontal. And we will see here we have a strong curve SPI, and for the hyperdivergent, we have a flat curve SPI. And curve SPI is a real determinant. And SPI, Ferdinand Graf von Spee, published this paper in 1880. He was a good observer. The curve SPI is a consequence of different axis inclination of the posterior mandibular teeth. If you look the inclination of the teeth, and if you assess on cephalometry the inclination of the different teeth, you have this type of results. That is in blue, it is a third molar. In red, it is a second molar. In yellow, it is a first molar. And in blue, it is a second premolar. Not a lot of difference following the skeletal type. Class 1, class 2, class 3, hypodivergent, hyperdivergent. Very stable. I worked on this subject for many years. Here it is, the pictures in 1983, 40 years. And you see here Rudolf Slavicek. He was member of my jury of thesis, and I am here defending my thesis on SPI curve. And it is published, here's a paper that I am very proud. It is a paper that I published at this time, 1985, with Rudy on curve SPI. And with this paper, it is a French paper here, we explain the reason of the curvus P and the relation between the radius of the curvus P and the morphology of the mandible. And in the morphology in the mandible, we are very interested by this triangle. The dimension between the condyle and the incisors, the height here between the condyle and the prolongation of the occlusal plane. And I call it DPO. Distance of plane of occlusion. And we have, at this time, 40 years ago, a formula between the radius of the curvus P and DPO. When you have DPO, you can assess very easily on the Ceph the DPO, and you have a proposition for a radius of curvus P. For the large majority of the cases presented, curvus P is ignored. If I look this case, this patient has a complete denture on the upper jaw and a partial denture on the lower jaw. She has a complaint from many years, a complaint of pain on the area of the palatal pain just behind the incisors. And she had a lot of set of dentures and total and partial dentures. And there is always the same pain. If you look the direction of the occlusal plane, the blue line here, or this one, it is the direction of the occlusal plane of the reconstruction. You can see a little bit the molar, maxillary molar here. And the direction of the occlusal plane is going down posteriorly. And the teeth was mounted following a rule, and I think it is a stupid rule, the rule in the middle of the crest. So you have the crest, maxillary crest here, mandibular crest here, and you take the middle to put the molar. So this situation is completely dependent from the resorption of the crest, not for the function, and the mechanical play of the force. When the patient closes, the force are not perpendicular to the occlusal plane. The muscles are here, elevators, turning around the condyle. It is like for the incisors, turning around, the cycle of closing movement, and the direction of the force are following the blue lines, right angulated to the condylar line. In this direction. If you separate the vertical component and the horizontal component of the force, the vertical component is absorbed by the denture, and the horizontal component push the maxillary denture forward and compress the anteropalatal area. and create pain. If you correct the inclination of the occlusion plane, you decrease a lot the horizontal component of the force. And if you realize, if you mount the teeth with a curve, you delete the horizontal component. And so the curve of P, listen to me, is not, the objective of the curve is not to facilitate the movement, to facilitate the chew. The curve of P is, the reason of the curve of P is static. It is the direction of the force when the patient is clenching first. And the teeth follow this direction. And your teeth follow this direction during the eruption of the teeth. The teeth align themselves following the direction of the force. One example concerning implant. The direction of the force is here, like this. And look at the direction of the implant axis. I think it is not optimization for the direction of the force.